a pleasure to be here this evening talking to you on a topic. Those of you who know me know that I'm very passionate about, so I will try not to keep you beyond our time. I think we're running on time, Chairman, are we? We're doing okay? Until I get behind the mic. So, conservative measures in physiotherapy. Some of my colleagues have stolen my thunder, so I'll be able to go through a few slides soon. What are physiotherapy conservative measures? So I'll go through what physiotherapy conservative measures are under the headings of what my colleagues have spoken about before me. Talking about stress incontinence, about urgency and urgent continence, about pelvic organ prolapse, and we'll just go through briefly bowel control problems and bladder and chronic pelvic pain. The terms I will abbreviate will be pelvic floor muscles and pelvic floor muscle training, because needless to say in physiotherapy they come up again and again. So what's the rationale for training and for using pelvic floor muscle training for stress incontinence? So lifting the pelvic floor muscles in an upward and forward direction prior to and during effort or exertion clamps the urethra and increases the urethral pressure, preventing urine leakage. And there's another component to it, and that's that pelvic floor muscle training improves pelvic floor muscle tone and may prevent pelvic floor muscle descent during an increase in intra-abdominal pressure. So an increase in intra-abdominal pressure then would be such as a cough, or of course it might be jumping, or any increase in exercise, and which in turn will then prevent urinary leakage. So let's just have a look at that within the context of pelvic floor anatomy. Do I have a pointer here? I do. So we have an at rest here and we have pelvic floor contracting, and you might recognise these diagrams just from my colleagues before me. On the left we have, just at the back, we have the position of the pelvic floor at rest. We have here the rectum, so that's the anorectal junction there at the back, and that is the resting position. And if you have a look at the position of the angle of the rectum there at the back on the left, and if you can see the change in the position from the back going up to the front to the urethra there. Okay, so you've got the resting position on the left and the contracted position on the at the front on the right. So where most patients, when they come into us in physiotherapy, assume that they're just contracting pelvic floor muscles by squeezing the muscles around the entrance to the vagina. It's always news to them that they have other muscles that are not just at the entrance to the vagina. So I would suggest at this stage in the evening, where it is conceivable that I will lose a lot of you for the next 15 minutes as I'm the last speaker, I'll just ask you to all do a pelvic floor contraction rather than just looking at that. So if I could get you all just to sit a little bit more upright in your seats and just shift around so that you're sitting on what you would feel are your sit bones rather than slouched back on more on your coccyx. So you're just kind of feeling like you're sitting on your sit bones. And now relax everything, not your posture, you're just that little bit upright, but you're relaxing your tummy and your pelvic floor muscles. So that's your resting position. So now I want you to think of, and I'll do a different, because great that we have a mixture of men and women, so I'm going to do a little bit of different chat for the male and the female anatomy. For the female anatomy first, I want you to pull in at the back passage, lifting up from the back, because you're going to be using all of this posterior anatomy, so all of this anatomy around the back area, as well as the anatomy around the front and the vagina and the urethral area. So you're pulling in from the back passage around the vagina, so you're going from the back and across from the back passage through the vagina and up towards the neck of the bladder, pulling up all the way from back up to front. Now hold that in there for the count of 1, 2, 3, 4, 5, and now release that all the way back down again. And for the men, you're pulling in around the back passage, and you have the benefit of feeling, and if you were to look at it at home in the mirror, seeing the scrotum lift up and the penis pull back in, so you can see much more action, whereas the women can't actually see the action. They have to just feel it and use images like this to visualize it. So for the men, you pull in at the back passage, you feel the scrotum lift up, penis pulls back in, you hold, feel it for 5, 1, 2, 3, 4, 5, and then drop completely. Now, two sort of thoughts that I want you to have when you're doing that. As you pull up, and everybody's to do this again now, thinking of your own anatomy and maybe looking at the picture. Don't get confused, thinking of the other anatomy while you're doing your pelvic floor exercise. So you pull up and in and hold in for your 1, 2, 3, 4, 5. Now drop that completely. And I want you to try and think, how much could you feel dropping? Could you feel everything dropping? Do you think your pelvic floor contraction was so good that you felt it going all the way up to, from the basement all the way up to the 6th floor, and could you feel it after that dropping all the way back down to the basement? Or do you think it was a bit sluggish and it got stuck on 5, 4, 3, didn't quite come down, or maybe didn't quite get up in the first place? Okay, so it's all about quality when we're doing a pelvic floor contraction. And then the other things you'd have to think of: did you just lift your chest? Did you block your breath? Okay, so there's loads to a pelvic floor contraction, and within that, a lot of the research will say that 50% of people get a pelvic floor contraction wrong when they do it. Okay, so it's not just blindly doing it. Okay, so. What about the rationale for pelvic floor muscle strengthening for treatment of urgency? So we do use voluntary pelvic floor muscle contractions to control urgency. The pelvic floor muscles contract to inhibit the detrusor contraction, and the detrusor contraction is that bladder muscle contraction. And so inhibiting the urgency to void, making it possible to reach the toilet in time and to avoid that leakage. But we don't quite know, and I can't quite tell you exactly how long, how many contractions, how long to hold, because the research hasn't quite figured that out yet. Okay, so we hazard a guess, and your local physiotherapist and will do the training with you, and we do go through with you, and we'll suggest, and sort of on to the next slide. And Sue did just a little bit on this, some suggestions as to what you might do. So when you are in trouble and you are at that part, those of you who have urgency will recognise this. You start off and you're in terrible trouble there, and you realise you're either coming to the hall door or whatever those other provoking, maybe it might be the shower, might be the hall door, might be just getting out of the car, might be seeing the door going into the toilet, and you're suddenly in terrible trouble up there at the peak of your urge. And these are the things that you need to do: the sitting down, the leaning forward, the pressure on the perineum, contracting the pelvic floor, breathing, what you need to do. And as Sue said, you might need to be doing that for a whole 2 minutes before you control your urge. So we know that it's going to take that amount of time to control everything. And what we're trying to do is get down the other side of this urge curve and trying to make it to the toilet. And if possible, distract for much longer and actually make it all the way out here, so that you're not even at that point in time going to the toilet, and we're trying to widen and widen the gaps. So what about with pelvic organ prolapse? Do we think it works? Pelvic floor muscle training works for prolapse. Well, we do know that it does, not for every prolapse for sure, and certainly some of the images that Jerry showed us for prolapse, certainly for some of the more severe prolapses, we know that pelvic floor muscle training doesn't work for some of them, but certainly for some of the milder prolapses it does, and it works very well. It can improve a stage in prolapse, and that's how high up a prolapse will go. And it can certainly improve women's symptoms, and that's the most important thing, is that it improves somebody's symptoms. So what happens then, that elevation of the pelvic floor muscle and closure of the levator hiatus, and that's the width of the vagina. So that'll happen with pelvic floor muscle training, and both of those elements will compensate for the loss of those passive supports, which is the connective tissue support and the descent of the organs. So what is pelvic floor muscle training? We have two components to it. We have to look at strength training, and we have to look at endurance training. And with strength training and with endurance training, we have to be quite specific with what we're doing. With strength training, it is short duration contractions with high load at near maximal intensity. And with endurance training, it's lighter loads with submaximal effort and higher repetitions. Training 3 times a week, and this is according to exercise principles, training 3 times a week is sufficient for strength training and for muscle hypertrophy. And with muscle hypertrophy, we're talking about just if you image the bodybuilders and the some of the the sort of the stuff and the pecs and the abs and all of that sort of real muscle hypertrophy, so that muscle building. So training 3 times a week is sufficient for strength training and muscle hypertrophy, if effort and repetitions are optimal. So what is optimal in terms of effort and repetitions? So it's not as much as you might think. So you may have been trying 200 repetitions as instructed or as you read on the internet, and 200 repetitions in a day is not necessary or practical or needed for pelvic floor muscle training. So according to exercise principles, 8 to 12 contractions in terms of strength training, of moderate velocity, increasing the load, and this is the important part, that you would increase the load, that by following exercise principles that you increase the load, and that you do this 3 to 5 times a week. For endurance training, you need to be practicing approximately 15 repetitions, light to moderate loads, and that would need to be at a 40 to 60% of what the maximum potential is for you to contract that muscle. Okay, so not the maximum. You will know, those of you who have practiced pelvic floor muscle training, and if your physiotherapist has asked you to contract your pelvic floor muscle and asks you, and you do this by all means, as you are, if you've been asked to contract your pelvic floor muscles and breathe at the same time, and that is suddenly impossible for you to do, very often it's because the load that you have been trying to practice at is too high, and that you need to bring down the effort and bring down the load to something like this 40 to 60% in order to be able to hold longer, in order to be able to train your endurance, so that you might be mixing up doing a strength training where you should be doing an endurance training. And then the other thing that is really important to practice is the knack. And the knack is how you switch on your pelvic floor muscles prior to doing or prior to exerting at all during any exercise, particularly during a cough, that you would pull up your pelvic floor muscles and then do your cough and then release your pelvic floor muscles. Or if it was going to lift a child that you knew you were going to have a problem, then you would just pull in the pelvic floor muscles and then lift up. Sometimes when people are caught out, and this is something that nobody ever volunteers me with, but it is a question that I ask my patients sometimes, that I say to them, do you ever have a leak when you shout? And sometimes it's to a young mother who has 4 young children, who is of course going to spontaneously let out a shout, and she always just laughs, and yes, she does, and that's always one of our provoking things, but it's never something she's going to tell you first off, that yes, when I let out a yell at my children, I leak. But that sort of one, you just don't know, a sneeze or a shout like that, you don't know. So then does pelvic floor muscle training work? So there are all the principles of it, and does it work? Well, according to the research, yes, it does. Women treated with pelvic floor muscle training are much more likely to report cure or improvement. They report better quality of life and have fewer leak episodes per day and have less urinary leakage on short pad tests. Now, pad tests, you can relate to that. If you do have to wear a sanitary towel as a result of having leakages, that means that you would have to wear either lighter pads or wear less pads over the course of the day. So by doing pelvic floor muscle training, it should be that you're wearing lighter pads or have to wear less pads. Treatment effect might be greater in women participating in supervised programs rather than unsupervised programs, and in programs that last at least 3 months. All right, that's what the research has shown us. And here's some good news, because this is often a question that I'm asked, that women with older age have been shown to have similar effects, that is not a disadvantage, because that's often a question that people ask me. They would say to me, am I at a disadvantage because of my age with pelvic floor muscle training? And there hasn't been any evidence to show that in the research. What about adjuncts? We know that biofeedback may have a role as an adjunct, and it is certainly used by physiotherapists, and it has been shown to have a role, including in the treatment of bowel dysfunctions, and we certainly use it a lot with treatment of bowel dysfunctions. But resistance devices, there hasn't been any particular extra effect to be shown by resistance device, and certainly anybody who's Googled it all with all of this will have used exercise cones, Kegel exercises, and people come into us with various devices that take out of our bags and show us, what about this, what about this? But certainly there isn't any evidence to show that these devices are any more helpful. So the role of the physiotherapist will be, in the first place, education, and we do try and educate from the antenatal classes onwards, postnatal classes, and then thereafter with leaflets in the hospitals, very often with videos, with postnatal exercise classes on videos. There's very often in the hospital settings a physiotherapist there at the end of the phone, and often physiotherapists have said to me that their patients don't phone up to find out what's available in the hospital, that there is often more available. You can access a physiotherapist through hospital referral, through public health nurse, through GP referral, gynae clinics, perineal clinics, through the community and through private practice. Our Irish Society of Chartered Physiotherapists, we have a special interest group called Chartered Physiotherapists in Women's Health and Continence here in Ireland, and they have a particular list of physiotherapists who have an interest in women's health. And then within our physiotherapy assessment, we would do an assessment once the patient is happy with it. We do suggest a vaginal or, where appropriate, a rectal examination, depending on whether there is bladder problems or bowel problems. And we will always be assessing the tone and the strength of the pelvic floor, the quality of the contraction, the quality of the release, whether somebody has pain. And we would generally do that in the context of an extended musculoskeletal examination as well. And through all of that, we'll be trying to determine what type of treatment the patient needs. Is it muscle strengthening? Do we need to facilitate the muscles? Do we need to be releasing the muscles? Are the muscles very tight? Certainly if somebody's got very tight muscles, very painful muscles, the last thing we want to do is start about a strengthening program. We may well want to release the muscles first. And then do we need to do bladder retraining, or would we need to be doing some manual therapy to release everything before we move on to the strengthening? And then what is the best type of treatment following our assessment, and what's the best type of teaching? We may teach just through palpation, we may teach through biofeedback, which has a visual component to it. We use real-time ultrasound for teaching pelvic floor exercises as well, and we may send the patient home with an electrical stimulation unit in order to get the pelvic floor muscles going. And certainly with home exercise programs, we need to ensure that the patient has gone home performing the correct type of pelvic floor exercise. Adherence is a huge problem. There's extensive research going on within the physiotherapy world at the moment with regard to adherence to pelvic floor exercises. We try and get our patients to carry out and to use home exercise diaries and to report back, and we just try as much as possible to come in for repeat visits. In the ideal world, you would have regular contact with your physiotherapist. Follow up. Research again has shown that effect may be better if a program is maintained for at least 3 months, and supervised physiotherapy is better than non-supervised. And long-term maintenance, the good news is that one set of 8 to 10, 12 contractions of your pelvic floor only twice a week in the long term is enough to maintain what you have achieved in your 3-month program. So in conclusion, pelvic floor muscle training works in the treatment of pelvic floor disorders, for some disorders and not for everything. Okay, so when I should have just a little caveat in there. And research is ever increasing and ensures good practice when attending a physiotherapist. Thank you.